program, which was a faculty development program in improvement science, and I did that last year. Most of the people doing that are residency programs because it's a requirement, but I was interested in the intersection of health services research, informatics, and information science, since those are the pools that I play in. So as Vishnu said, I actually don't necessarily know all of you, so I'll just tell you that I am here in DMICE upstairs on the 5th floor. I do a lot of my work in the Evidence-Based Practice Center, the ARC-funded systematic reviews, but I also do a decent amount of guidelines work for other people, and then I have an interest in primary research in shared decision-making and long-term care and aging. So Matt is one of the faculty members for the FISC program, and he's also was the VA chief resident for quality and safety, and he's currently the improvement science lead now for the program, and the VA chief resident of quality and safety leads that program. And he'll tell you a little bit more about himself in just a second. But I wanted to tell you, why I wanted to do this. I wanted to just talk a little bit about what improvement science is, and that's mostly what Matt's going to talk about some topics and focuses and approaches that people are using in improvement science. And then most importantly, I want to try to start a conversation about what improvement science and informatics can do together, both here at OHSU and more generally. So quickly, we'll get more into this, but I wanted to show you this because I think that these fields really do overlap in a lot of interesting ways. So improvement science is about strategies to improve healthcare delivery, safety, and policy. Informatics, you all know, but I wanted to see this, is about how to use data to improve health and delivery of services. And then health services research, where my training is really about how the system works and how you can create information to help people choose the right care and improve health care through delivery systems. So we are not the only people thinking about this. I just wanted to show you the cover of one report that I came across when I was starting to think about this, which was about how health IT could support quality improvement in primary care, and OCHN was actually one of the case studies for this. And what I thought was interesting in this is a couple of the key lessons learned were about that IT, which we all know, but if you think about how we can do this and where it overlaps with improvement science, that health IT needs to go from just documenting visits to actually generating data for change, and that how it's used is really important to think about when we're designing tools. I thought that sort of applies to what a lot of students are doing right now. So I want to turn it over to Matt, who's going to give an intro and some overview of things you might be interested to know about improvement science. And then Dr. Scott is going to talk about what they've been doing in family medicine. And then I have a couple of slides from the third person who couldn't make it today that I'll share with you. And then hopefully we'll have a couple minutes to discuss. So let's see if I can do this. Okay, and so there's, oops.
Okay, thank you. Thank you for having me here today. As Annette mentioned, my name is Matt Diveronica. I'm an internist by training. I completed my residency here in internal medicine. Followed that up with a year of the chief resident for quality and safety at the VA, which is a nationally run VA program. Since then, I've been serving as the OHSU GME faculty lead for improvement science, helping to run the House Staff Quality and Safety Council, as well as the Foundational Improvement Science curriculum that Annette mentioned. And then clinically, I'm a hospitalist at the VA, the Director of Quality for our hospitalist group, serve on various quality and safety committees as well at the VA. So I have a passion for improvement and safety efforts. And I'm glad to be talking to you guys today about this topic. But as Annette mentioned, I think the first thing is really to define improvement science. And, I went to Google to see what does Google define improvement science as. And notably, there was 760,000 results there. Digging a little bit deeper into them, if you look at the IHI, the Institute for Healthcare Improvement, their webpage on improvement science is simply just an explanation of the PDSA cycle. There was an article in 2013 in The Lancet called Promotion of Improvement as a Science. They don't even really define improvement science, but the closest they get to it is that it draws on and aims to contribute to clear and explicit theories of how change happens. Don Berwick, former CMS chief, one of the founders of IHI, he defined it as the applications of the approach developed by Deming to reduce variation in industrial processes, so a little bit of a narrower definition there. Interestingly, you could go to King's College in London and probably other places around the U.S. and get a master's degree in both implementation and improvement science. And on their website, I found it interesting because they clearly describe what implementation science is, but only describe improvement science as the practice of improvement. Here at OHSU, we now, at least within the School of Medicine, tout the third science of healthcare delivery, of which they incorporate improvement into. So I think what you can get the sense of is that this is still a relatively new term in that pre-paradigm phase where there's not a consensus definition of what it includes. And so my working definition, I really liked yours, Annette, and I think we probably overlap pretty much here, is that it's a set of strategies and tools to improve healthcare delivery systems and ensure effective and safe patient care. And it has both relevance to the discovery of new strategies and tools as well as the application of them. And I think the key points here obviously being improvement and to the systems with the ultimate outcome of effective and safe patient care. And you could really expand that even further into 4 key components, which are known as the Deming's system of profound knowledge. And I believe that pretty much all of improvement science can be categorized into one of these 4 areas. Appreciation of a system and how they function, building knowledge and testing theories, understanding variation and how to respond to variation, how to interpret your data and know whether or not that the variation that you're seeing is either a random variation or significant variation that's worth acting upon. And then there's the human side of change, or the psychology to change management. And pretty much everything that you do within improvement science can be grouped into one of these 4 domains. But no matter, I guess, like practically speaking, what you end up seeing or hearing currently out there in the world of improvement is probably terms like lean, model for improvement. You've probably heard of Six Sigma, and there's even a combination Lean Six Sigma, which I'm not sure I could tell you all the differences between them. You're less likely to have heard of things like focused PDSA or improved method. For those who have been in this field for a while now, you probably have seen the coming and going of continuous quality improvement. But no matter which approach you choose to use, it's all about having a system. And so for those that provide patient care, this is Sir Luke Files' famous painting from the 1800s. Here you can see the doc is being thoughtful and thorough, we're going to presume thorough, and has a systematic approach to his patients, much like those of you who do provide patient care. And no matter what it is that your role that you fill, you have a systematic approach. So for the physician, it's taking a history and doing a physical exam. You'll then order maybe some labs or imaging. And then you'll try a test of change, whether it's a medication or a procedure of some kind. And your hope is that you then obtain a change in health, and hopefully that it's a positive change, but recognizing that there are some potential negative changes. And in improvement, it's really the same formula. You hear about a story, maybe it's an error, maybe it's that you're not meeting a certain metric, or you just want to improve care in a certain area. You go to see it in action to understand the process better. You perform your exam. You'll maybe collect some data. Maybe it's chart reviews or patient data, or perhaps it's the literature, and seeing what is the best evidence that we have on this. And you'll design a test of change, all with the hope that you're going to provide a change to the system of care delivery, and again, hopefully it's a positive one. And if you believe this Paul Batalden quote, that every system is perfectly designed to get the results that it gets, then you will buy into the notion that having a systematic approach to changing the system will then prevent those errors from reaching the patient or improve the quality of care that we deliver. So why is improvement science important? Well, hopefully, if that didn't get you, for those that are physicians, you know, we took a Hippocratic oath, and I think most doctors probably think of that as a very singular act, that I won't harm the patient, but I'm of the belief that if we continue to allow systems to harm patients without trying to improve them, that we're probably not holding up to that oath. You know, there's the idealism of course, I want to improve my work and improve the care that I want to provide. But I think the realities can sometimes set in that there's that doesn't happen, or those that, you know, believe that the way that they do things is the best way or the right way. But I think the real reason why this gets increasingly talked about, and probably what you guys are feeling, is the pressure. Pressure from your prospective students or the current students to say, I want to learn more about this. Your payers, whether it's CMS or insurance groups that want to provide only value-based payment. Various regulators, JCO comes in, OIG comes into the VA, and accreditors, and for education as well. So ACGME or whichever professional body or accrediting body that you have to respond to is demanding that this is now taught and learned. And so hopefully you can get a sense that the time really to learn about improvement science and start participating in some of these activities is really now, and I might even argue yesterday. So some of the efforts that are going on here at OHSU for faculty training, we are wrapping up our second year of the FISC program, which is an a 9-session curriculum designed to teach both the basics of improvement science, the foundational knowledge, as well as the curriculum development and pedagogy, and try to pair the two of them together to then create curricula to bring for those that attend, will then bring that curriculum to their various programs. Mostly we've had, as Annette mentioned, residency programs from GME, because that's where our funding stream has come from, but we've also had Annette here representing DMICE, We've had nursing, doctoral nursing program representatives, and we've had several UME, undergraduate medical education representatives as well. For residency, for training the residents, not only are we getting the outcomes from the FISC program and new improvement science curriculums being taught to the residents, we also have the OHSU House Staff Quality and Safety Council, or OHSU HQSC, and you can check out their website at ohsuhqsc.org. And this is a resident-run group, which I help to, I'm the faculty advisor and lead for the group, that is focused on education for the residents and partnering with hospital administration to try to bridge that gap between education and hospital functions to have this group be in charge of improvement projects across the institution. So what, if you wanted to, if you had further interest in improvement, what are some of the things that you could be doing today? OHSU has the OHSU Performance Excellence System, or OPEX, which you may have heard of before. They offer various courses, which you can sign up for online if you go through the O2 website. For those of you that may be at the VA, you can sign up for lean belt training. They have the various colors, yellow and green and black belts to signify the level of expertise. And those are the things that are recognized nationwide as a certificate. The IHI has the Open Schools, an excellent resource for those that like online modules and perhaps have limited time. You can do these at your own leisure, and if you signed up through your .edu email address, they're free. You just have to make sure you use the .edu email. There's a great Harvard edX massive open online course, which has already just completed for the spring, but if you went to the edX.org website and signed up for notifications, they'll usually run it again in the fall. And for those that like the book and the self-guided adventure, I would highly recommend the Improvement Guide, which was I remember my first foray into learning about this. And you can probably find that on Amazon for some $25 or $30 or so. Hopefully it is becoming increasingly recognized, the importance of providing the education for improvement science because of all the various pressures that we are seeing from outside, from external and internal sources. I'm hoping we can kickstart the conversation today on what else we can do with the DMICE program to provide some of that. So, thank you.
I have a question. I'll start. That's why I started. And that is, you mentioned effectiveness and safety in the definition. I'm wondering where, I'll use the word efficiency, but what I really mean is dollars. Where does dollars fit in regards to?
Yeah. I took out my one slide that I had the various frameworks for measurement of effectiveness. So thank you for bringing that up and calling that out. So that certainly is in there, and it's a personal working definition, and it probably should be in there. But I look to the IHI, who has the triple aim and now even the quadruple aim, and yeah, so. Okay, I need to unhide this first. Okay. So So here's the triple aim and the quadruple aim, which were developed by Don Berwick and the IHI, and they do have the cost per capita in there. The quadruple aim incorporates the provider and their experience and their level of satisfaction. The alternative framework that is most popularly used is one that was popularized by the Institute of Medicine back in 2001 as their follow-up to the quality chasm. And here they have their 6 domains of measurement for care. So does that answer?
Yeah, I was just wondering whether you thought improvement science included those broader issues or not.
I absolutely do. Yeah.
You mentioned the program in London where they had improvement science. Sorry, you mentioned the program where they had improvement science and implementation science together. And in my mind, I don't see how you could separate them.
It's a great question. I think it's the implementation science I think of as the sort of the application of what is learned from improvement science on a much larger scale. So personally, I don't function, I don't have the background of the implementation science because I see it as, I think of a great example would be the Michigan central line infections, which is a popular story. And so it tends to be on a much larger scale beyond the single site or even 2 or 3 single sites, but addressing how do you take what is successful in one hospital setting and developing it so that it's successful in many other hospital settings. So they do go hand in hand, and probably for this master's degree, it makes sense to combine both of them.
But I was thinking, just even at OHSU, if we're thinking about, think about any application, right? So I'm a methodologist. I can have a great method or theory, but if I actually don't understand how it gets implemented or the culture, the organizational aspect, then it seems like we could go wrong. So it was just that, when you made that comment, I kept thinking, oh, they always have to be together, like, kind of co-cultured.
Yeah, I think that's a point well taken. I'm not sure if you have any additional thoughts.
You know, the funny thing is, you were asking the question. I was thinking about. I need to turn my mic on. I was thinking about the concept that the ankle bone is connected to the knee bone, and yet we have ankle specialists and we have knee specialists. I'm a family doc. I'm actually wondering why the patient injured themselves to begin with, and the concept that I'm a generalist, okay? And so what you're really describing is what's the right level of specificity that you want to get to. I don't know if there's a right answer to that question. I think there are needs probably across the board. There's a need for the generalist and the family doc, and there's a need for the orthopedic specialist who does the knee, and an orthopedic specialist that does the ankle. It's okay. I think it really depends on what your demand is and what the needs are of your community.
Yeah. Vishnu had a question? Vishnu, okay.
So I kind of practice on what Shannon had to say, which is clearly to make improvement science mainstream, there are going to be changes in workflow, there are going to be changes in practice, but there's also needs to be a change in culture. And you can change the culture by education, which is something that we can do easily in the undergraduate or in the graduate medical education level. I was curious to your thoughts about what the best way or the optimal way to change the culture for people who are actually in practice, in the trenches, in the community, outside the academic medical centers, because we need them in order to make the whole system better.
Yeah. So how do we change the culture of the practicing providers? From my experience, I found that you have to demonstrate to the providers that there is value in change. It can often be so hard for somebody to recognize that what they're scope is in the larger field of their clinic, and it can be hard for them having that narrow focus and that narrow worldview of how they function to understand the value to the clinic as a whole, or even the value to the patient, or wherever their care setting is. So finding an effective way to communicate the value usually done through good stories, and then data to back up the story is going to be the way that most people respond. Some people will respond to authority and say, because the dean said it, this is important, we're going to do it. So those, I think, are the three: telling a good story, having data to support the need for change, and having the support, at least. You need the support, the buy-in of leadership. And so those, I think, are the three main components. Operationalizing that is a little bit harder. Yeah. And it's a long-term process. And I think even just from my time here, I've seen lots of resistance that has started to melt away.
So Shannon asked my question, but I have a new one now. What's the evidence that this works? Is there strong evidence? I know it's a huge effort.
That what works?
Improvement science. Does it work as compared to, say, continuous quality improvement or any of the other buzzwords?
That's.
Do you want to?
I think they are all buzzwords. I don't think it matters what you call it. It's about the process that matters. And I think there's tremendous evidence in, I'll say, the manufacturing world around this, and we're just beginning to scratch the surface as it relates to the health community and the medical system overall. But when you have stories, because we do have stories here at OHSU where we've made big differences in outcomes for our patients, that it really matters. So yeah, I think there's tremendous evidence for it.
And I will argue that there is a larger preponderance of evidence to make change rather than to do nothing at all. And I don't think anybody in here would say that doing nothing is an acceptable answer. And so my major argument would be that if you need to make change because we've decided that doing nothing is not an option, then having a systematic approach will only increase your efficacy.
Great. So
Well,
go ahead. I'm hoping we're going to have some discussion then.
Yeah, one last question, and it kind of ties into, you talked about the changing culture, and one of the ways is to demonstrate value and to demonstrate that what you're going to do is going to work. But all you, maybe not all you need, but what can happen is that if you implement something and it doesn't work, that can be the ammo that groups and providers can use to say, this doesn't work, so why should we do it? And in the setting of failure, in the face of failure, how do you continue to motivate people to say that the process is important even if we find failure? That's great on a theoretical sitting in a meeting, but when you're talking about providers interacting with their patients, that's much harder to convince. And so just kind of interested on how do you deal in implementations that do fail and to continue to motivate them to say, this failed, but let's work on the next project because that can succeed.
I would argue that learning something is never a failure. So you may do something and it may not work, but the very fact of learning that it doesn't work is actually value in and of itself. And if you can get the culture to believe that, then you're in good shape. But you're right that you can't fail to improve every single time. If you never improve, you're never going to get there. But if you learn some negative things in the way, that's what science is all about, including improvement science.
It's the Edison light bulb.
Right.
Yeah.
Right. I'm going to take over. Is that okay? Thank you very much. So it's a great honor to be here. I've gotten to interact with Vishnu on working to get fellows at at OHSU. For those that don't know, OHSU is a non-for-profit company housed in downtown Portland that places electronic health records and other technology tools in federally qualified health centers and rural health centers throughout the country. And as such, we have about 20 million people on that electronic health record system more broadly, and therefore a single data warehouse that houses that, and from which we can do significant research and scholarly pursuits to actually learn what works and what doesn't work. So that's my role as CMO, is to try to develop tools as it relates to data to help improve the care of patients. We have 2 of the fellows that have been there already, and if there are other fellows in the room, you'll eventually get there. Look forward to it. I'm the former vice chair of family medicine here. I am professor emeritus, which means that I get to say things and nobody cares what it is anymore, which is good. So today what I want to do is share with you a story and maybe tell you a little bit about how we developed our culture. And what I would like you to do is to think about your own environment. This is our story, but immediately start to think about, what does it mean for you? If you're a clinician, think about what you do clinically. If you're not a clinician and you fit somewhere in the system, figure out where you fit, because this is a team sport. This is not about what I do. It's about what we do. And so as I go through this, feel free to interrupt me, challenge anything that I have to say. I might be wrong, okay? All right. So this is a hypothesis. The healthcare system is changing. Might be, might not be. I don't know. They're voting right now. You know, God knows. The way that success is measured is changing. The way that success is measured is changing. The way that we interact with the healthcare system is changing. And the we can be clinicians, staff, patients. Everything is changing is the hypothesis. And then, and this is, I think, really important to all of us who work in healthcare, and I think it goes to why in healthcare making these changes is more difficult. It's about individual patients. And we all are unique snowflakes in our own way, okay? As patients, we're all unique snowflakes. And so the fact that the patient-clinician relationship is still the foundation of providing care to patients, that's my hypothesis, that that's still there, okay? Maybe changing. It is changing, I would say. But this is part of what we're doing. So in terms of evolution, we're focusing on outcomes, decreasing costs, the patient experience, and the clinician experience. This is the quadruple aim, just put in a different way, that you just heard about. I said this is evolution. You know, being able to focus on outcomes is totally driven by the ability to have data. We weren't really able to focus on outcomes because we didn't have data. And when we went live here at OHSU in 2005 on Epic, it was in some ways really the first time that we had the opportunity to get data out of the system. We can put as much data into the system as we want, but unless we get data out, then it's worthless. And so this is the electronic health record, and our abilities to have data warehouses has really changed our ability to do this work, this improvement science work. So where the health system is going, new payment models, new ways to incentivize the system of care. So if you are around or haven't been around the healthcare system, we've been driven by a fee-for-service methodology for probably 40 to 50 years now, okay? Maybe longer, depending on how you want to think about it. Now, we are starting to move towards population health criterias. So in other words, how is a group of patients doing as opposed to any individual patient? And on another hand, we're doing pay for performance, which is how well am I doing taking care of patients. We'll talk about some of the pluses and minuses of that. So as you change the payment structure, the incentives are changing. My incentive as a clinician has changed some over time as the payment model has changed. So about 20% of my payment comes in the form of what's called capitation or per person payments. Now, for those of you that are old enough to remember managed care in the late 80s and 90s, it's the same idea, but in the 80s and 90s, we didn't actually have data about how we were doing taking care of those populations. Now we actually have the data. Makes a big difference. So if the delivery system changes, how will quality change? And this is all about aligning metrics. So if you're going to, incentivize people, you need to make sure that the things you're measuring actually reflect what you're trying to accomplish. And so this is a lot of what we're doing right now in healthcare. And it's very controversial. One of the things that has driven this is actually the ACA. This is a map of those that have done ACA expansion and those that haven't in the gold. And the states that have moved in this direction are moving much more towards data-driven care because, again, they're looking at populations. It has led to a much greater level of administrative burden to the practices. I want to acknowledge that. There's administrative burden to this practice. But is the juice worth the squeeze, if you will? And so, we're trying to figure that out. And I'm going to give you some ideas about that. This is the building blocks of effective patient-centered medical homes that was described by Bodenheimer. You say, well, wait a minute, I'm not in primary care, or I'm not in health care. Doesn't matter. To me, actually it does, because it actually was discussed. The number one thing here is an engaged leadership. Okay? If you don't have an engaged leadership, you're not going to be able to drive that cultural process. But down here on the bottom are engaged leadership, data-driven improvement. Empanelment is about knowing who your patients are, knowing who your patients are. So, if you work in a pulmonology clinic, you have to decide, who am I responsible for? Because if I'm responsible for them, then there are some things that I probably should be measured about and get that information. So empanelment matters, and then the reality that this is a team sport that I already mentioned, and that the outcome is not dependent on the clinician, which as a clinician is both freeing and for many clinicians is scary. Okay? So one of the things that you run into in terms of resistance is, I don't want to give up my control of what happens to patients. All right? And so that's part of what we have to get past if we're going to be successful with this. This is probably the most important slide that I have in this deck. How many of you guys have worked in a clinical environment? Okay? So when you go in, somebody tells you how to do the work, right? You get trained. And when you get trained, you then go and you do it. I don't care what it is, but you go do it. In this case, patient care. From that, we're beginning to get data back. So we've done the patient care, we're getting the data back, and then you create an improvement strategy. This is the same idea of the slides that you've already seen, but then you do a plan, do, study, act process, maybe just a STUD process, I don't know. And then you have to redesign. And then you retrain to that design. So what we all need to get a cultural phenomenon about is that things change. People hate change in general. Okay? We like it the way it is. And that's just part of the reality. But if we do this process, then you get quality and improvement in patients' health. And for me, that's all that I really care about. I want patients' health to improve. All right. So when you get data, it's really seductive to define things as being good or bad, or people as being good or bad. And you really need to always ask the question why. So in my practice, for instance, and we're giving data to our clinicians on an ongoing basis, and somebody is doing, quotes, better on the metrics than somebody else, the first question should be, why are they doing better? Is there something in their workflow that's different than the other people, and that's why? Is there something different in the substrate, i.e. the patients that they have that make it different for them? I don't know what the answer is, but if you go into this process in a punitive fashion, it's one of the fastest ways to not allow that cultural shift to occur. Okay? Now, that means in our department, we have not tied any of our data to compensation. So none of our data about quality of care is tied to compensation. That was a choice that we made because we wanted people to do it, quotes, for the right reasons, i.e. improve the health of patients. It was never a goal to have clinicians make more money. That was not our mission, okay, and is not our mission. Our mission is to improve health. So one of the choices that you have to make is how closely aligned you make the payment systems to the metrics. Just something to think about. This is really important in today's world because if payers are paying you based on performance, then one of the things that you run a risk of is for people to make choices about how to maximize that revenue that hurts patients. Example, you all are diabetics, let's say. This group over here are really, really tough diabetics, okay? Really tough. You're tough because you don't take your medicines. You're tough because you have really significant disease. You're tough because you drink alcohol. You're tough, okay? This group is perfect, okay? This group is, just very simple. Which patients do I want to take care of if my revenue is based on the data, okay? I want that group. Good luck to all of you, okay? That is actually part of what's happening in the vote today, guys. Watch it. Watch it. It's happening today, right now. In order to gain and buy in from the clinicians and staff within the healthcare system about measurement of performance, it is critical that there be accurate empanelment. I talked about that. Who are my patients is the first questions. So that is because of accountability and responsibility for the care. So that means that any patient in our world, the definition is any patient who has me listed as a PCP and has been seen in the clinic in at least once in the last 3 years is mine, okay? And our patients in the clinic is any of those who have any of us listed as a PCP and have been seen in the last 3 years. We made that up, okay? Now there is some national discussion about what it means, but in many clinics it's 1 year. In some clinics it's 2 years. You could make a difference depending on specialty. Okay, we're continuity providers, so we value the concept of continuity. So if just because you came and saw me for a well adult care 3 years ago, I consider you still my patient because I'm responsible for the health maintenance that might happen along the way. Okay, does that make sense? So there you go. Then why are we seeing our patients? So who are we seeing? Who are my patients? And then why are we seeing them? And that's driven by the problem list, the visit diagnosis, procedures that we do, and then even just reasons for phone calls and things like that. So the first question is, who are my patients? The second question is, why am I seeing them? And so my diabetic patients are any patients that which I'm listed as a PCP and the patient has been seen in the last 3 years in the clinic and has a diabetic-related ICD-10 diagnosis on the problem list. That's our definition, all right? So definitions matter, and when you're doing definitions and you're going to give data to people to use, the first thing you need to do is actually run the definition by them. You don't get to tell people what the definition is. You have to take a cut at it, give it to them,
and get buy-in. That's part of the cultural shift that has to happen. They have to own these metrics. If they're not your metrics, they're your metrics, okay? And as long as things are being done to us by governments, federal or state, by payers, then the clinicians will not buy, and the clinics will not buy. Health systems will not buy. All right. And then, how well are we doing caring for our patients? Notice this is really the question that you all care about, but you don't get there until you know who you're taking care of and why you're taking care of them. You can't get to the how well until you get there. So you can have what are called process indicators and outcome indicators. You guys familiar with those terms at all? Yes? No? Maybe sometimes? So if you all are, then I won't waste too much time on it, but process indicators means, did I do the right thing to the right patient at the right time? Okay? An example, flu shots, okay, or any other immunization. I'm supposed to give you the right immunization at the right time to the right people. Does that make sense? Versus outcome indicators. I'm supposed to measure hemoglobin A1Cs in diabetics, but what the number is the outcome, you could say. Okay? Some people would define that as an outcome. So if the hemoglobin A1C is bad, am I responsible for that? And the answer is maybe. But the challenge that you have to think about is whether or not you're going to tie payment associated with this. Because if you're going to tie payment, then again, these people will receive no care from me, okay? Because for whatever reason, even if I screwed up, okay, if I can't get that hemoglobin A1C down below 9, then I don't want that patient in my practice. It's really simple. I want all of you guys. You guys are great, okay? And so that's what we're watching, okay, and what all of you need to watch in healthcare about whether or not you're asking me to do things or asking the system to do things that they actually have control of, okay? And we would argue in our practice that we don't have really good control of the hemoglobin A1C. That doesn't mean that it's not a good goal. It doesn't mean it shouldn't be measured. It just means that tying my payment to it is not wise, okay, in terms of moral hazard. So how well am I doing for caring for my patients? How well are we doing caring for our patients? These really depend on what level in the organization we're going to look at. So we can look at what I call an organizational level, which is our entire department. We can look at a specific clinic. We can look at a team within the clinic, or we can look at me, okay? And so you can decide, and in our place, we give them all because it all matters. We want to see whether or not there are 4 teams. There are 4 teams in our clinic down at South Waterfront. We want to see if one of the teams is doing something different than the other and why, right? The question's why. So then we also care about what's going on at South Waterfront, but we care what's going on at Scappoose, Richmond, and Gabriel Park just as much. And so they get there, and then maybe one of the clinics is doing better, okay? And ultimately, we compare what OHSU Family Medicine is doing against the internists, who we also do some reporting for, and they do some reporting of their own. But we care about what the internists are doing because we're doing kind of the same thing. We care. And we look at this nationally, too, of what's going on. Okay? So who we're measuring and you know, who we're comparing ourselves to. We want actionable information. And populations are about systems of care. So this was about you know, how to build systems. And I said everybody is a snowflake, and that is true, but they're all snowflakes. Okay, so you want to know how to take care of snowflakes the best you can, but you have to be able to individualize it to some degree because you're all individual snowflakes, unique snowflakes. All right, this is the slide that I am most proud of in my 32 years, got past another decade. 32 years of being here, okay? This is a bunch of different indicators, and all that you need to be aware of is that they're getting better, Okay, they're going the right direction. And you don't need to read them. But what this means is actually people's lives. Okay, this is actually people's lives. We know that if people's hemoglobin A1C is under better control, that they have less complication and are less likely to die. Okay? We know that if we give Pneumovax to the elderly patient or those with high risks, that if we do that, less of them die. Okay? So these are people's lives. And so this demonstrates that we have a system of care within our practices. It's not just about one indicator. So the idea being that if you choose one of these, you need to then think about what the standardized aspects of that process are that you can then translate across multiple venues. Because if you don't, what happens is you focus on Pneumovax, it gets really good at the same time that hypertension control goes down through the floor. Does that make sense? You've got to build a system that does more than one thing at one time. All right? So that's a really important thing. All right. So what is success like? Getting a true understanding of the quality of care, the cost of care, and most importantly, the outcomes of care. Outcomes being defined as patient's health, not a lab test. Okay? That's it. Yep. Go ahead. Go answer. While she's doing that, ask the question.
What I want. Okay.
My question is kind of around the idea of outcomes and patient's health, because I think that can be difficult to define sometimes. And in this case, what I'm really asking is, how do you think you bridge the gap or balance something like what we might consider to be an objectively good patient outcome, such as, take back pain as one of these difficult ones where your back pain gets better, and then also balance that with what is the patient's level of satisfaction with the experience of healthcare that they had. And so, I'm not referencing any particular piece of data here, but to say like back surgery versus no back surgery.
Yes.
Maybe there's no difference in the amount of functional back pain or ability of people to walk or level of disability after the people who didn't have surgery or they did, but whether maybe the people who did have surgery felt like they got a more kind of more treatment.
Right? Absolutely.
And how do you balance that idea in terms of like, okay, here we've got like quality of life adjusted years, and here we've got like just I'm happier. Yep.
So the interesting thing is that we actually know from research that when we ask a patient, how do you feel? That actually is an incredible predictor of health, the likelihood that they're going to get hospitalized or die, okay? And so knowing how people feel about their health is really, really important. What you're describing, though, I'm going to say, is some of that cultural stuff about education. So it's about being willing. It is much easier for me to order an MRI of the back than it is to just sit down and describe to them why it's important not to do that, okay? It's much, I can do that. And with that back, man, I can just pump that baby out. And guess what? In the current system, I'm incentivized to do that, okay? Because this building is built on MRIs, all right? And so let's do more, all right? But the problem is that we're going to go broke as a healthcare system, and that's why it's changing. That's why the system is changing. And so we're also beginning to get paid for the conversation a little bit more, okay? And that's part of the incentives changing for us. I actually have time to do that.
So very quickly, I want to mention one thing, and maybe we'll do a session next year, but originally I'd hoped that Elizabeth Crabtree could be here as well, but I just want to point out she is faculty in DMICE. A lot of you probably haven't met her yet because she's very busy, because her main position is as the Director of Clinical Integration and Evidence-Based Medicine, and I just wanted to point out that how that's connected to all the improvements, some of which is through the value-based care and the payment, but this is something that's happening here at OHSU, and she has a presentation that we can have her come do. But I want to point out that one of the things they're doing is a course, an interprofessional course, and just make sure that you're aware of her. So in the couple of minutes we have left, the main thing that I was interested in starting to get you all to think about, and why I wanted to do this Grand Rounds, was, like I said, I'm interested in this, and I went through the FISC program not because DMICE has a residency, but because I was sort of interested in what they were teaching faculty and what residents are doing, but also in thinking about, are there bridges between what DMICE faculty and students want to do and the improvement science efforts in the hospital and in other departments and divisions. So I'm best, in the couple seconds we have left, if, I'm looking for ideas on, is this something that should fit in DMICE somewhere, and if so, where? How should we explicitly address it in classes? Does it fit with our research agendas or with our own policies and practice? And really interesting things. The reason I was impressed with Dr. Fields, and he didn't say this, is family medicine has invested a huge amount of time, money, and expertise. They hire probably more analysts than any other department, so they actually hire people that come out of our types of programs, and they actually do a lot of that analysis now for other departments, which is and that's a system he built. And so I know we're at the end, but if anybody does want either A, have a comment or an idea of how we could sort of connect things, and then B, hopefully we can continue this going forward.
I keyed in, you mentioned the difference between documenting a visit and generating data for change, and I think that's really important, and I think that's kind of the shift we're seeing in informatics, where a decade, 15 years ago, is all about implementing systems and learning how to do that well and getting over the adoption curve, where now we're more into analytics. So I see it totally being complementary. I would argue for interweaving it in every single class that's possible, especially on the clinical side. Dr. Mohan's class would be a great place to introduce it, but it wouldn't be I think it could be an overarching theme that might fit with many classes.
Other comments or ideas? So, Karen?
Yeah, so right now there are a couple of new announcements from ARC that are specific to clinical decision support and implementing current or new things and disseminating them. I mean, it feels to me like we're going to need a partner to do this.
Yeah, and I hope ARC still is open and accounted for. Absolutely.
I know.
But I do think that was something, me taking the FISC course and listening to what family medicine has been doing long before FISC started, and then what some of the newer departments who are coming into it because now they have to. But they were really very engaged. It was a really interesting experience. So, the residency programs have to do this for certification, but the people who are trying to design it really want to do it well, I think. I was pretty impressed. And, it seemed like there could be more connections between DMICE students and those programs or DMICE faculty and faculty wanting to do more long-term projects that could fall under, the rubric between what's research and what's improvement science. I mean, they're both important, and I think those should fit together too, but that's a whole other discussion we could have. So I would like to do something useful in this area, and I don't know what it is, so I was hoping to use this as a way to start to get some ideas. Is it, some resources to add some things into some classes? Is it working with some students who are interested in this and going through people like Matt or Scott to find connections to build projects that build these bridges? And so I know we're done, so these were just closing, the standard, you can't improve what you can't measure, but I'd argue it's not just measuring, it's monitoring and understanding it. And then he talked about how you don't like change, but the Winston Churchill quote is, to improve is to change, and to be perfect is to change often. And that's essentially what we're working on. So maybe this is something that we can continue next year, but I wanted to at least get it started. So thank you all for coming today, and thank the people who are joining us remotely. And any last question? I think we're at time, so I don't want to make people late. Okay.
I'm happy to stick around either inside or outside to answer any questions that people might have.
Yeah.
This is really exciting work, and so the stuff you're learning actually matters. And you know, and that was right. We hire people in the department that do this work, but so do other departments here that are doing this well. And so it's a burgeoning area, that's for sure.
As does the VA too.
Absolutely, absolutely. Yeah. Thanks. Yeah.
Thank you.
Thank you. Appreciate it. Sure.
I have them all, so I can do that. Sure. I haven't merged them because then we all did.
Can you do a PDF of it?
Yeah, I'll
Thank
make
you.
a PDF.
Thank you.
Yeah, I'll do a PDF.
Thanks. It's fun.
Yeah.
I enjoyed hearing your thoughts. Yes, ma'am.
So, the project that I didn't get into detail about is that we have a shared decision-making tool for women in their 40s to decide when to begin mammography.
Mammography, absolutely.
And we have hit barriers trying to implement here, just as nope, it's time, we'll do this. But really what we want to do is the tool assesses for breast cancer risk, and the 3 clinics that participated in our initial evaluation study love the fact that they found out who the women were that were above average risk, so they could reach out to them. So we want to we're doing a soft implementation here with probably Katie Benzing and her clinic.
Okay.
But if ARC still exists, and you know the House just passed it, passed the repeal while we were talking.
That's okay.
Yeah.
They still got to go through the Senate.
And when does the money piece come into it? Because I think what they're passing is going to be expensive. But
Yeah, not until the Congressional Budget Office does its assessment, which it hasn't yet. They passed that without knowing what it's going to cost.
I know. So anyway, if ARC still exists, and I realize that.
Yeah. Well, right now they do, at least until September, because they got a huge funding in the budget reconciliation, which goes through September. There's $2 billion additional dollars for NIH and research overall.
For NIH, but
Yeah.
we don't know what's going to happen to ARC yet.
Understood.
But the stupid part is that ARC also is the same agency that figures out pill A costs 3 times as much, and it's the same equivalent to pill B that's cheap.
Yeah, I understand.